Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thanks so much, Brian. Yeah, really happy to be part of this group. Thanks for inviting me. This is just a slide indicating that, we're going to get into a little bit in the weeds on federal regulations that impact OTPs and other aspects of the care of patients with opioid use disorder. And just to acknowledge that hopefully this is important information or useful information for folks providing HIV care so that and counseling folks who may have comorbid substance use disorder on, how the treatment landscape looks and might be changing. And I really think we're kind of in a transformational moment as far as the type of care that might be available to folks with opioid use disorder from opioid treatment programs. This is kind of the agenda. Just spend a couple minutes on each item, and I'm going to start by just reviewing. I think it was a few weeks ago we talked about really focused on the changes to one particular part of the Code of Federal Regulations that really impacts the operation of opioid treatment programs where buprenorphine and methadone can be dispensed for opioid use disorder. And then spend a little more time on some other changes that affect OTPs or office-based opioid prescribing. So this is just a one-slide summary of the stuff we talked about last time. As of April of this year, there were probably the most substantive changes to the regulations which govern how opioid treatment programs function since the designation was created 50 years ago. And really is trying to shift the emphasis onto provider autonomy and patient-centered care and away from what I would characterize as a pretty single-minded focus about avoiding or minimizing any risk of diversion at the cost of, patient access or low barrier care. So there's much more flexible guardrails around provision of unsupervised or take-home doses of medication. I think that's probably the most impactful change here, that folks who engaged in treatment in an opioid treatment program with methadone, a few years ago, who are saying that, I really can't go every single day to the clinic to have this treatment. That's not necessary anymore. And there's a lot more flexibility to make those decisions and balance community and patient safety with accessibility of the treatment. There's a lower barrier to treatment entry. It really aligned with office-based opioid treatment now. So folks with a moderate to severe opioid use disorder by DSM criteria are eligible for admission to an OTP if they're over 18. And if they're under 18, if they've got parental consent, there's no special additional eligibility requirements as there were in the past. Counseling is recommended, required to be offered, but not required for patients to engage in to have medication treatment. And there's a lot more flexibility now in allowing more aggressive methadone starting doses, which will allow hopefully some increased rates of medication titration. We know that we often lose folks to treatment early in the first couple weeks. And there's a hypothesis out there that it's part of that challenge is that folks are not achieving a dose where they experience any benefit. So they're kind of losing hope and dropping out of treatment. So there's some flexibility for programs to be more aggressive with initial dosing. Telehealth intake and visits is explicitly allowed now, which is great. And then there's more flexibility around BID dosing for methadone for folks with a compelling indication like pregnancy or rapid metabolism or chronic pain, where, taking advantage of that 8 to 10 hour analgesic window, you might get better pain control with BID dosing instead of the consolidated once daily dose. And then there were some changes in that Code of Federal Regulations that basically included long-term care facilities and carceral settings that have a DEA hospital clinic license in the category of hospitals as types of facilities that can initiate or continue methadone without the involvement of an OTP. So just as a hospital can, if a patient's admitted for endocarditis, dispense methadone while they're there, that same provision is now accessible to nursing homes and jails and prisons. And there hasn't been very robust uptake of this just yet, but I think there's a lot of potential for that. Moving on to other regulations. So the DEA made some changes that really is going to allow for much more access to what they're calling mobile medication units. And in the old days, we called methadone vans. This is a type of treatment that was developed in the late 80s. The first one was in Amsterdam, and the first one in the U.S. was in 1988. Really designed to harm reduction tool to reduce HIV transmission among people who use drugs and facilitate access to OTP care in rural communities or in communities where all the regulations around siting of a brick and mortar clinic were creating barriers to opening clinics in those areas. And since the late 80s, the DEA would kind of authorize these on an ad hoc basis. But in 2007, they actually issued a moratorium on licensing any further mobile medication units. And that was in place for 13 years until 2021, when the DEA essentially lifted the moratorium. And in addition to that, they actually made the licensure process a lot easier. These units would not have to seek their own OTP licensure, which is a very laborious bureaucratic process, but could be kind of added components to an existing OTP. Shortly thereafter, SAMHSA allowed block grant funding to go to the purchase and upkeep of vehicles. So they're really trying to promote this modality of treatment. And it's starting to spread. As of April of this year, there were 42 operating MMUs in the country. And Washington State is really one of the states kind of on the leading edge here. There's 8 of them in our state and more on their way to being licensed. This is just a picture of one of the ones at the Opioid Treatment Program, ETS, where I work. And it's a kind of retrofitted RV, and it allows for the delivery of all the core services of an opioid treatment program in the community. So there's a little exam room in there you can do medical exams. There's a counseling space, and then there's a dispensary space for the dispensing of methadone or buprenorphine. In Western Washington, we have 2 vehicles like this and 2 more on their way. And it's been interesting. If at the end I can kind of, if folks are interested, share a little bit more. They're not a panacea. Between setup and takedown, you're really pretty limited to 1 or 2 sites a day in our experience, but a great way to expand access. So it's kind of what I was mentioning. There is no additional federal siting requirements. So you want to, make sure you're working closely with communities where you want to be providing this care. But unlike a brick and mortar OTP, you don't have to get any type of approval to deliver care via mobile medication units in different communities. And there's not a lot of evidence out there about this. There was a recent scoping review, and there were 4 studies altogether, 3 cohort analyses and 1 kind of before and after analysis. And there was this suggestion in these small studies that mobile services were associated with an enhanced retention in care compared to fixed site brick and mortar clinics, and that they appear to facilitate access for particularly marginalized populations that are hard to reach. Just a quick word, the federal regulations around opioid treatment programs make reference to fixed site medication units. These have not been implemented anywhere in the country to my knowledge, but they're essentially like mobile units, but they're not mobile. They could be co-located in a pharmacy or a hospital or a clinic, an FQHC, and allow for med storage, dispensing, essentially kind of a satellite for an opioid treatment program. Washington State, I think other states are working on this, are actually undergoing a rulemaking process to try to promote implementation, because there's obviously a lot of potential if satellite OTP could be, set up in an area of high need, that might be a great way to expand access to specifically to methadone. Okay, I promised I would not talk about OTPs the whole time. So this is a federal rule that impacts other treatment settings, a change in a rule. Folks may be aware that for a long time there's been this provision in the law that allows, though you're not allowed to prescribe methadone for opioid use disorder in the outpatient setting, you can dispense it for 3 days as kind of a bridge while someone's getting set up with ongoing care at an opioid treatment program. And I know at Harborview, the hospital where I work and where I trained, we were making use of this on folks who were admitted to the hospital and say they were discharging on a Saturday and they couldn't get into their opioid treatment program on a Monday until Monday. They could come back and be given a dose on the Sunday. So that's been allowable for a long time. I don't think there's been great uptake, but recently in August, they changed the language in this regulation to allow dispensing of 3 days of medication at one time. So it doesn't seem like a big change, but I think it probably can be leveraged to really support some interesting ways to initiate treatment. In neither the old nor the new version of this provision is the site of care specified. So though it's primarily been used at hospitals, there's no reason it has to be. And this provision could be utilized by emergency rooms, by withdrawal management facilities, or clinics. And in fact, there was a study I have some figures from it conducted a couple years ago in Boston at BMC, looking at utilizing this provision to initiate methadone at a bridge clinic, a hospital-based bridge clinic. So this was a clinic where they were seeing a lot of folks with opioid use disorder and initiating buprenorphine, but they were seeing a lot of interest in methadone, particularly as fentanyl became more prevalent in the community. And so they utilized this provision it was a hospital-associated clinic, so they could use their inpatient pharmacy to directly dispense, I think they did it through their Pyxis system, methadone that they would dispense to the patient at that visit, and they could come back for a total of 3 days to be redosed while they were being connected to an opioid treatment program. And the linkage rates were pretty fantastic. I mean, almost hard to believe, but 86.8% of patients who were of the 121 patients, 105 of them actually linked. That means made it to their intake at the opioid treatment program, after 3 days or however long it was. And of that total sample, quite a few were still in treatment at 1 month. There's a lot of literature in the buprenorphine side of things about ED initiation, how starting the medication at that point of service when the patient is seeking care or interested in care is much more effective in promoting linkage and ongoing retention than just a referral. And I think this is the first study of hopefully many that shows that same principle probably applies for methadone too. So I know there's a lot of interest among emergency rooms to try to do something similar. I'm not sure of any place doing this at scale yet, but Scala Northwest, which is a new collaboration between University of Washington and some other stakeholders, created this guidance for emergency rooms. And the website there at the bottom, they have all sorts of topics related to inpatient and emergency room treatment of opioid use disorder. And one of them is how to leverage the 72-hour rule to initiate methadone in the emergency room, some guidance about dosing and documentation. And hopefully this would be a guide for emergency rooms looking to do this. Of course, the missing piece is you got to be in an area where there's an opioid treatment program to link to. And that's, depending on where you practice, that just may not be at all a feasible option. And I'll just comment that at Harborview, we're looking to kind of follow the BMC model and see if our hospital-based clinics can utilize the 72-hour rule to initiate methadone for folks. I know the MAX and MOD clinics, our lower barrier HIV clinics, have a particular interest in that. And so the hope is that we could, initiate methadone in clinic and facilitate a expedited referral to a community opioid treatment program. I think folks are aware, so changing tack again. So at the end of 2022, as part of the Consolidated Appropriations Act, the X waiver to prescribe buprenorphine was eliminated. So obviously this is a big deal. Anyone with a DEA license can prescribe buprenorphine now. It's a Schedule III medication. It has the same regulation, treated like any other Schedule III medication at this point, including the ability to add refills. There's no patient caps as there were in the past about how many patients an individual practitioner can treat. You do need to attest, as I'm sure everybody's aware, for a DEA license, obtaining a DEA license or renewing a DEA license, that there's been an 8-hour training in substance use disorder education. So in some ways, you could say the data waiver has been eliminated, or it's been required for everyone to have the DEA license in a certain sense. And then telehealth bupe. So there were these provisions made during COVID to allow for telehealth and telephone initiation of buprenorphine specifically during the emergency. There was a proposal from the DEA to roll this back, or elements of this back. And there was overwhelming public opposition to this during the comments period. And so they've actually extended, DEA and HHS has extended all that telehealth flexibility until the end of this year. So we'll be on the lookout for another try at regulating this by then, or another extension. But right now, buprenorphine can be prescribed by audiovisual telemedicine or telephone. And that's allowed for some things like in King County in Washington State. Sorry to be so Washington-centric, but in the county where I practice, there's a hotline that's been set up by the public health. And it's a 24-hour a day. It's a number that they can call and speak to a provider and get a prescription and instructions on how to self-initiate on buprenorphine if appropriate. And then they're also connected to a care navigator to kind of figure out next steps for ongoing care. So that's, a direct, I think they've started quite a few patients at this point. And this is only possible, given that regulatory flexibility. This next one's a little bit in the weeds, but folks may be aware that quote unquote Part 2 programs, so programs that hold themselves out as providing and do provide alcohol and drug abuse diagnosis treatment. So substance use disorder clinics essentially are subject to more intensive privacy regulations than HIPAA. And specifically, they, until recently, have required explicit signed ROI to allow any communication with an external entity, even if it's for care coordination. And it had to be specific to that entity. So if my patient at Harborview was getting treatment at Evergreen Treatment Services and OTP, we would need an signed ROI to allow communication between those two entities. But as of February of this year, basically a patient can opt in and say, yes, I want my SUD program to be able to communicate with anyone who is now treating me or may treat me in the future for my medical care, like is allowed under HIPAA, and really bring it more into alignment with HIPAA. So hopefully this will contribute to breaking down some of the silos that exist between substance use disorder treatment programs and general medical care. And this is the last item that I wanted to discuss. I think we touched on this a little bit last time as well, but there is an act that was proposed in the House and the Senate, bipartisan supporters, or sponsors, I should say, that would allow for board-certified addiction medicine or addiction psychiatrists, physicians, to prescribe methadone for OUD, and prescription could be filled in a retail pharmacy. So really a big change. And I think it's in the Senate, it's in the Health, Education, Labor, and Pensions Committee, and it's in the Subcommittee on Health in the House. It's very, I wish I had more know-how or to know how likely it is to pass or not, or it's has created some controversy in the field. I think the American Society for Addiction Medicine is in firm support of this, and the trade organization, Professional Society for Opioid Treatment Programs, has actually come out in opposition to it. My own opinion, well, I can share some kind of provisional data. So this is an interesting study that was trying to kind of get at, well, what might the effect be on access of something like this? And this was in Health Affairs Scholar, a journal that I wasn't familiar with, but it looked at basically census tract data and reasonable proximity to either an OTP, FQHC, and whether or not you're in a mental health shortage area, to try to get at what would be the change in access for folks if MODA passed and addiction specialists were allowed to prescribe, or if all DEA registrants were allowed to prescribe methadone for OUD. And the kind of orange here is people who live within 20 minutes drive in a suburban or urban area from an opioid treatment program, 30 minutes in a rural area. And, very limited, as we know. 80% of counties in the country do not have an opioid treatment program in them. And then opiate addictions, this light blue is kind of thinking, okay, if you added addiction specialists, these additional areas folks might have access. And if you added all clinician prescribing, the dark blue, these additional areas might be included. And they kind of break it down by urban, suburban, and rural. And you can see, of course, in the rural areas, allowing addiction specialists might more than double access, and allowing all prescribers would significantly improve access. So thought that was interesting. Just, projections, obviously, but yeah, interesting to think how that legislation might impact access to methadone specifically.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button, and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.